Okay, I will go ahead and get started. First, thank you everybody for joining us. This is our second to last T&E Foundations Curriculum lecture for the 23-24 academic year. And just some of the same kind of reminders that we have every time. Everybody is welcome to ask questions. Those that are panelists, you are welcome to unmute yourself and turn on your video if you would like to in order to ask your question. Those that are not panelists, please put your questions into the Q&A. We will be able to follow the questions much more easily if they're in the Q&A box and not the chat box. The chat box sometimes gets filled with lots of other things. Remember that we do have a session evaluation. We do listen to all of the things that are put into the session evaluations, and we make changes to the series depending on those evaluations. So please take down the QR code now, or I will show it again at the end of the lecture. And so with that being said, I will introduce our speakers today. It's going to be an interesting session today. And we have two speakers that will be kind of sharing the floor, talking about ECMO physiology. So Neil Patel is a neonatologist at the Royal Hospital for Children in Glasgow, UK. He is also the Clinical Innovation Director, Clinical Lead in the West of Scotland Innovation Hub, Honorary Clinical Associate Professor at the University of Glasgow, Senior NHS Research Scotland Fellow, and a Scottish Quality and Safety Fellow. And then Florian Kipfmueller is an attending physician in the Department of Neonatology and Pediatric Intensive Care Medicine at the Children's Hospital of the University of Bonn in Germany. He is board certified in pediatrics, neonatology, and pediatric intensive care medicine. So let's please welcome both of our speakers to the Foundations Curriculum Series. We've been having a lot of people on our evaluations requesting ECMO physiology as a topic, so we finally have gotten them to be able to give us this. So I will stop sharing my screen and hand it over to you, Neil.
Thanks very much. It's great to be here, and really looking forward to sharing this talk presentation with Florian and my colleague. I see lots of familiar faces have joined as well. I'm going to share my screen. Hopefully everyone can see that. Great. So I'm going to start by introducing the concept of physiological type of pathophysiological approach to the patient who requires ECMO. And then I'm looking forward to handing over to Florian, who's going to start to get into the nitty-gritty of the patient on ECMO and their management. If we take a step back, all of us will understand the challenge, I think, of managing that extremely sick newborn infant who's in that spiral of deteriorating clinical picture of hypoxia, acidosis, systemic hypotension, usually indicating a failure of normal transition, perhaps with an obvious cause, but perhaps not. And when we start to think about the potential for ECMO, we're really at the limits of what our medical management can achieve for this patient. And I think on a clinical decision-making level, it can be really challenging. And so what I hope to share with you to begin this talk is a really physiology-based approach that can help us to make sense of which patients might benefit from ECMO, but also how we might manage them in the preparation for ECMO, during ECMO, and then coming off ECMO as well. Some of the questions that may be running through our mind as we're faced with a patient, as we stand at the end of their bed and see them in this perilous clinical situation, are, is this patient the right candidate for ECMO? What benefits might there be to them, but also what risks might that bring? What mode of ECMO is going to be appropriate, VA, VV, perhaps even some combination of those two for a particular patient? What's the long-term potential of giving this treatment, both in terms of short-term benefit, but long-term adverse effects? And actually on ECMO, how are we going to manage this patient? How are we going to make the right decisions that will help us to see them truly benefit from ECMO and minimize the risks associated with it. First of all, just a mention about ECMO terminology, because you hear these different terms, ECMO and ECLS, and I quite like this distinction that's made in by some colleagues in a recent seminars review. They make the point that ECLS, extracorporeal life support, is a more generic term. It refers to prolonged cardiopulmonary bypass via extrathoracic cannula in the setting of acute reversible cardiac or respiratory failure. And it encompasses not just our traditional ECMO circuit, but also ventricular assist devices, artificial hearts, and I would argue also potentially bypass during cardiac procedures in theatre. ECMO is more of a defined term, extracorporeal membrane oxygenation, that we tend to use to refer to this temporary bypass provided in the intensive care unit, or indeed in the emergency department before we get to the intensive care unit, to augment oxygenation, ventilation, and cardiac output. But it doesn't usually refer to complete cardiac bypass. So from here onwards, when we're talking about neonatal ECLS, I'm really going to use the term neonatal ECMO. I want to start just by giving a little bit of a sense of the demographics or epidemiology of ECMO in our current practice. And happily, we have data from a recent ELSO registry to help us understand that. This graph shows all patients submitted to the registry, both adult, pediatric, and neonatal, from 2009 up to 2022. And what you see is, over that period, an absolute increase in the number of patients who've been treated with ELSO, particularly in the recent COVID years, 2020, 2021, and 2022. But you can see that is driven predominantly by an increase in adult ECMO. If you look at the darker shades for neonatal and pediatric ECLS, you can see that there has been a relatively steady number of neonatal patients receiving ECMO in the recent years. Overall, you see a drop-off in 2022. That's driven, as you see, partly by a reduction in the number of centres that are delivering ECMO. There was a steady increase through the COVID years, but it's also, as you start to see here, perhaps associated with a slight reduction in neonatal ECMO. And we can see that much more clearly in these graphs from a recent review by Alison Rose and Sarah Keane, which summarized data from the ELSO registry. On the left-hand side, you see all neonatal ECMO runs from 1990 to 2020. And overall, there was a reduction in the number in the perhaps mid to late 90s, but we had a fairly steady number, perhaps an uptick in the later 20-teens, but that's now coming down again. If we look only at neonatal respiratory ECMO runs, so we take out indications that were primarily for cardiac indications, you can see the picture is slightly different, and that there's a trend that has started in the mid-2010s that continues into the 2020s of probably a reduction in the total number of neonatal respiratory ECMO runs. There are probably a number of reasons for that. First of all, with improved obstetric practice, improved neonatal intensive care practice, there are a number of patients who are avoiding neonatal respiratory ECMO. But there may also be factors associated with changes in center-specific management of patients. And it's not that we don't want to put patients on ECMO, it's more that we're managing to treat them medically. With this slide, I want to give a little bit of an overview of what we'd like to cover in terms of neonatal ECMO physiology for the remainder of this talk, but also to make the point that when we think about the ECMO patient, that really begins well before they go on to ECMO. First of all, it may start with this kind of pre-indication, a sense of a patient because their fetal diagnosis or perhaps a family history, where we think actually this is a potential ECMO candidate early on. Examples of that would be patients with congenital diaphragmatic hernia or perhaps with airway anomalies. Or it's a sense that we get in the early postnatal course in the first minutes, hours of life, that this is a patient who may require ECMO. And at the bottom of this slide, I've really tried to indicate about who is involved in recognizing that we may have a potential ECMO candidate in their management. And of course, that doesn't start in the ECMO center. often starts with colleagues in referring centers and with our transport teams who have the challenge of initially managing this patient and the task of recognizing a potential ECMO patient who should be discussed with an ECMO center and potentially flagged up for transfer. Even within our own ECMO centers, we have this sense of a patient who we might call an ECMO watcher, where we think, yeah, this patient, by dint of their physiology, their underlying diagnosis, may require ECMO, and we need to be ready for that possibility. But what this also highlights is that there's a substantial number of patients who we may think and prepare for them to go on to ECMO, but who actually may at the end of the day avoid it. And that might be a very good outcome for that patient. But it's to recognize that when we talk about ECMO physiology, we also need to think about the pre-ECMO physiology and our ability to manage some patients away from ECMO. The other thing that this really highlights, and I think is probably the most important message, if there is any, about managing ECMO patients, is that this is a multidisciplinary team approach. It starts with those colleagues who refer these patients into the ECMO team. It continues with all of those different members who form an ECMO team, and it includes those colleagues who will look after a patient after ECMO for many months and years afterwards. So for the purpose of this talk, I'm going to focus on what are the indications for ECMO and what is the pathophysiology of the patients who we take onto ECMO, because that will then be key to decision-making around the mode of ECMO we might choose, the approach to cardiorespiratory management and monitoring on ECMO, and our approach to expectation of complications of ECMO and mitigation of those. I'm also going to touch on contraindications for ECMO. So if we think about neonatal ECMO indications, one way of approaching it is to say, well, which conditions are associated with ECMO use in neonates? And therefore, if a patient has those conditions, might we be primed to expect that this patient could require ECMO if their condition doesn't respond to medical management? And this is data, again, from the registry summarized by Catherine Fletcher and Rachel Chapman's recent review of the conditions of neonates, the underlying conditions that were associated with ECMO use. And you can see if you go back into the early 90s, it was predominantly patients with meconium aspiration syndrome, with what we lump into a group called persistent pulmonary hypertension of the newborn, persistent fetal circulation, group of patients who also had RDS and sepsis, and a relatively consistent proportion of patients with congenital diaphragmatic hernia. There was this other group that we called other, represented in green here, who were a minority in the 90s, but who have subsequently grown. And what you see here as we come up to the 2010s and 2020s is that there are many fewer patients with meconium aspiration syndrome. There are many fewer with that classic diagnosis of PPHN, although that in itself may be a little bit of a diverse group. There are certainly fewer patients with RDS and sepsis going on ECMO. As I said, CDH patients remain a relatively consistent group, dropping down perhaps from around 20% into the teens now, but that other group has grown substantially. So who are that other group? Well, and again, going back to that review by Alison Rose and Sarah Keane, they explored who that group of a primary diagnosis of other was. And what you see actually is that a substantial component of that group are actually patients with a primary diagnosis from the other groups, meconium aspiration, CDH, sepsis. But there are some other significant diagnoses in this group. For example, HIE, alveolar capillary dysplasia with malaligned pulmonary veins, ACD-MPV. I've highlighted a few others, airway anomalies, AVMs, omphalocele. The reason I've highlighted these is not for any specific reason for these diagnoses, but more to show the diversity of these conditions. And I want to come on to that in a second when we think about the pathophysiological mechanisms that underlie these patients needing ECMO. Just to go back to those main groups of patients who require ECMO, the other thing that I want to highlight is that there's diversity in terms of the duration of ECMO support that they required and also their survival, as you see highlighted in this table. So if you look at diaphragmatic hernia, you can see that they are by far the commonest reason for runs in this group of conditions, but they are also the group that has the longest ECMO runs, followed by meconium aspiration syndrome. Survival is also quite variable. For CDH patients, it's somewhere between 50 to 60% overall, whereas for other conditions, including meconium aspiration syndrome, we expect much higher survival on ECMO. So what are the indications for ECMO? What is the underlying physiology that leads to a patient going on ECMO? If we look at the recent neonatal respiratory guidelines from the ELSA registry by Taylor Wild and colleagues, you can see that they start with this indication of a patient has severe respiratory or cardiac failure with a high likelihood of mortality and potentially reversible etiology. So that's a fairly broad overarching definition. But then they say with one of the following, either inadequate tissue oxygenation despite maximal therapy, severe hypoxic respiratory failure with acute decompensation, an oxygenation index which is elevated with no improvement, or severe pulmonary hypertension with right or left ventricular dysfunction. I just highlight oxygenation index because historically that's often been used as a particularly significant criteria for ECMO. In these particular guidelines, and it wasn't stated here a specific cutoff for oxygenation index. Florian is going to talk to you a little bit more about how we calculate oxygenation index. In our own practice, I would say that we use the oxygenation index as a global measure of severity of impaired oxygenation in patients, but it's not an absolute value. And I think that we need to step away a little bit from using an absolute cutoff of oxygenation index, particularly because the way it's calculated, we can adjust the nature of it by varying mean airway pressure and inspired oxygen level. So to some extent, it reflects clinician response rather than underlying patient physiology. These are recent guidelines for the management of diaphragmatic hernia treated with ECMO from Yeet Gunnar and colleagues. And when you look at the indications here, they become a little bit more specific in terms of classifying hypoxic and hypercapnic respiratory failure in terms of ventilator settings, but also pre-ductal oxygenation and PCO2 and hydrogen ion. They also provide some criteria for circulatory failure in terms of oxygen delivery, hypotension, and cardiac function. And they also have this additional criteria of acute clinical deterioration, which is change in pre-ductal saturation or hemodynamic instability. So they provide perhaps a little bit more objective criteria for ECMO initiation or ECMO indications for ECMO. I would take it a step further and say, if we go down to individual patient pathophysiology and can understand the driving factors behind what is contributing to oxygenation failure, failure of adequate blood flow and blood pressure in these patients, and failure of CO2 clearance, then we start to get more of a nuanced picture of the underlying patient physiology. And that can help us in terms of our subsequent ECMO strategy and management strategy on ECMO. So I want to just take a few minutes to think, what are the underlying patient pathophysiologies that can give rise to this kind of common clinical phenotype of hypoxia, impaired oxygen delivery, hypotension, and hypercarbia? Well, I would say that it usually boils down to a combination of a relative contribution of these four components. First of all, parenchymal lung disease and/or airway disease. Secondly, pulmonary arterial hypertension, by which I mean abnormalities in the pre-capillary pulmonary circulation, usually associated with a combination of pulmonary vascular vasoconstriction due to pulmonary artery smooth muscle contraction, or structural abnormalities of the pulmonary arterial circulation, as we see in congenital diaphragmatic hernia, for example, combined with a contribution of cardiac dysfunction, and in particular, the potential for left ventricular dysfunction, primary left ventricular dysfunction, giving rise to increased left atrial pressure and pulmonary venous hypertension as an alternative mechanism of pulmonary hypertension. And then finally, I think we also need to think about what is the relative contribution of increased metabolic demand in a patient, particularly a patient with sepsis, and associate with that the potential for metabolic dysfunction, which may be primary metabolic dysfunction in the setting of an inborn error of metabolism. And you can see that depending on the relative contribution of any of those, they can contribute to hypoxia, hypercarbia, hypotension, reduced systemic blood flow, increased metabolic oxygen demand, and therefore contribute to imbalance between oxygen delivery and oxygen demand in the tissues, and relative anaerobic metabolism and increased lactic acid production. And if we think about this in the context of specific conditions, the patient with classic acute pulmonary hypertension or persistent pulmonary hypertension in the newborn, I would argue, has predominantly a situation of failed pulmonary arterial relaxation and therefore pulmonary arterial hypertension. I would say actually that pure pathophysiology is relatively rare. In the setting of meconium aspiration syndrome, where there's mechanical plugging of the airways and alveoli, we probably have a combination of that parenchymal lung disease component, plus a failure of pulmonary arterial relaxation, and there may be an extent of ventricular dysfunction as well. What about sepsis? Again, due to impaired cytokine signaling in the pulmonary arterial vessels, there may be primary failure of pulmonary vasodilation, combined with increased metabolic demand in the tissues, giving rise to increased oxygen consumption. But that may be coupled with a degree of ventricular dysfunction, contributing to reduced cardiac output, and if there's significant left ventricular diastolic dysfunction, pulmonary venous hypertension. Congenital diaphragmatic hernia, which is a condition that really fascinates me, we can see variations on those three components highlighted here, both pre-capillary pulmonary structural changes in the pulmonary arterial circulation, post-capillary left ventricular dysfunction giving rise to pulmonary venous hypertension, and of course those abnormalities of the airways and the lungs, which are pathognomonic of CDH, with hypoplasia, both of the ipsilateral side of the diaphragmatic defect, but also at histological level, you see reduced number of airway branches, a rudimentary alveoli in both lungs. So this is really to highlight that although we may have a common clinical phenotype in these patients, the underlying pathophysiology may be quite different. And understanding that really helps us to think about our ECMO strategy. Our overarching strategy in ECMO in neonates tends to be one of two. First of all, either a bridge to recovery, where we want to support the patient and allow time for their natural recovery of their pathophysiology, and usually that's in the setting of the neonatal transition. It may allow us time to treat the underlying cause, for example, sepsis in the patient, and it also gives us time to optimize our cardiorespiratory therapies. There's no doubt in the past there were some patients who ended up on ECMO because our attempts to treat them from a ventilation and from a circulatory point of view actually exacerbated their dysfunction. And I think there's an underlying message there around a gentle approach to hemodynamic management that very much through the NHRC and other initiatives, many of you will have picked up. But in the bad old days where we used to crank up the dopamine, crank up the dobutamine, crank up on a high dose of epinephrine and norepinephrine, we probably were helping our patients to get to the point of needing ECMO rather than helping them avoid it. The other context of an ECMO strategy may be a bridge to a decision, and this may run in parallel with that concept of bridge to recovery. So it may be that the patient that we're putting on ECMO, we don't actually understand their underlying diagnosis and their underlying pathophysiology. And by getting them on ECMO, it's giving us time to investigate further, to come to a diagnosis, to understand the pathophysiology, and either to treat it and to support recovery, or if we realize that this is an underlying diagnosis where actually sadly there is going to be no curative treatment, then it may be time to have some joint decision making, including with that patient's family, and give them time together before reorientation to a palliative approach. The third ECMO strategy, which is bridge to organ replacement or bridge to a bridge, for example, bridging to longer term ventricular assist, tends not to be one that dominates within neonatal centers, unless that there is access to appropriate neonatal organ donation. But going back to this kind of pathophysiology-based approach to ECMO, I would take it even a little bit further in terms of our ECMO strategy. So it's not just a case of putting a patient on ECMO and then responding to the individual physiological parameters, it's a case of thinking a little bit more deeply about why have we gone on ECMO? Which of those different pathophysiological components that I showed you in the previous slides contributed to this patient's deterioration and their failure to respond to medical therapy? And then how are we going to use ECMO to support that? And what other therapies or therapeutic approaches are we going to use to then address that underlying pathophysiology? So for example, if the patient has severe left ventricular dysfunction and associated hypotension, I would argue that we want to support their cardiac function. There's a role for VA ECMO there, but we may also want to continue or think about how we're going to use cardiotropic support. And by that, I mean inotropic support, vasopressor support, vasodilator support to help that patient come off ECMO. And we may also need to think about what might be rare or metabolic or genetic causes for that left ventricular dysfunction that will input into our decision-making. If we have a patient who has significant contribution of parenchymal lung disease, and that's contributed to hypercarbia and ventilation failure, then it may be that that patient can be supported with VV ECMO. They don't need the cardiac support that comes from VA ECMO. And in that setting, we need to think about how we're going to help that lung recover and then recruit to enable weaning of ECMO. And what is the role for adjuvant therapies? What is the role for bronchoscopy, for CT as an investigational technique? Do we need to think about rarer causes, for example, surfactant genetics? And finally, in the setting of severe pulmonary hypertension, which mode of ECMO is going to support that patient best? And how are we going to optimize that patient's pulmonary vascular resistance, in particular their precapillary pulmonary arterial tone? Do we need to think about cardiorespiratory interactions and the use of pulmonary vasodilators in that setting? And should we explore rare causes, for example, alveolar capillary dysplasia with malaligned pulmonary veins? Historically, we used to investigate by use of lung biopsy, but we can now do genetic testing. Do we need to think about other factors in the maternal history that might have contributed, for example, SSRIs? So the message I'm really pushing here is it's not just a case of a one-size-fits-all therapy for ECMO. We need to think our ECMO strategy is guided by the underlying patient pathophysiology, and we need to really unpack that to utilize ECMO effectively. There are some patients for whom ECMO is not going to be appropriate, and we need to think about absolute and relative contraindications. I've shown here the contraindications from the neonatal respiratory failure guideline and from the CDH specific guidelines for ELSO. And there are some specific ones that both highlight. The first is the size of the patient and their gestation. As you can see here, generally patients less than 2 kilograms are considered too small for ECMO because of their vessel size. And below 34 weeks post-menstrual age, because of the increased risk of hemorrhage, in particular intraventricular hemorrhage, these patients are considered contraindications. These are relative contraindications, but there are absolute contraindications. For example, if a patient has a lethal chromosome disorder, an existing hemorrhage, including uncontrollable bleeding from any site, but also significant intraventricular hemorrhage. Severe brain damage is an interesting one because, particularly in the context of HIE, it can be difficult to assess in those acute hours after birth the extent of the hypoxic insult. And that can lead to some challenging decision-making around the suitability of a patient for ECMO. Just thinking about that issue of prematurity in patient size, this is data from the CDH ELSO registry and a case series that highlights the dimensions of patients who've been put on ECMO in the past. And you can see that those smaller patients below 2 kilograms have been cannulated in the past, but with reduced survival compared to term patients. The smallest patients that have been put on that have been reported that around the 1.5, 1.6 kilogram size. I'm going to stop there, and I'm going to hand over to Florian and look forward to your questions at the end. Thanks very much.
Great. Thank you, Neil, and thank you all for joining today. So I am just setting up my computer here and showing my conflicts of interest. I have some liaisons with the medical industry. Also, I have to report a conflict of interest because I'm working in a center where we almost exclusively use veno-venous ECMO for respiratory neonatal ECMO. So if it comes to question, I'm more familiar in this field compared to the VA ECMO, which is used much more around the world. But the physiology, the underlying is similar and comparable. And first thing, when we have the patient on ECMO, of course, it is important to determine which underlying disease is present. And this, as Neil already said, can and will define our therapeutic aims. So it is really a question whether in case of respiratory failure with pulmonary hypertension, whether it is a problem of the right heart or the left heart, if it's pre-capillary or post-capillary pulmonary hypertension, and whether the lung is the leading organ. So there are many indications, as we already said. This here is a picture, as you are all familiar, meconium aspiration syndrome has been a very common indication for ECMO. It's a little less frequent. Also, we have the preterm CDH babies or the preterm babies. They have a different physiology, of course, and different things to consider than other patients. And very rarely we have those with a premature rupture of membranes or with a renal oligohydramnios, which are rare conditions. But of course, these also have some very unique features that we have to consider. The basics. So the first couple of things, you probably have all done this very extensively in the past, but it is always important to come up with these equations. So the first thing we have to count is the oxygen content in the blood, which is determined by the hemoglobin and the oxygen in the blood, either the dose bound to hemoglobin or the dissolved hemoglobin. And additionally, we need to talk about the oxygen delivery, so the capacity of the body to bring the oxygen to the cells where it is needed, the DO2, and then the oxygen consumption, which is also important, what the how the body's ability is to consume the oxygen. And if we go to the DO2, the oxygen content as described by the formula above is one part, and the other is the cardiac output, which is pretty much determined by the heart rate and the stroke volume. And the stroke volume is influenced by preload and the cardiac function itself, right and left heart, and the afterload. So these are all basically the aspects that we have to account if we approach an ECMO patient, and if we look for different parts, how to improve the condition of the patient and eventually get him off ECMO, because that's the first thing to think about if the ECMO is initiated. How do we get the baby off ECMO? Here's a picture that a colleague of mine once were putting together, an illustration of the ECMO machine and the cannula in a veno-venous ECMO. This baby has a dual lumen abalone catheter in there, as you can see on the X-ray. And if we start the ECMO, here you can see the chart of the baby. It's a 12-hour-old neonate with a left-sided congenital diaphragmatic hernia with quite a severe type, and the patient was initially doing well with oxygen saturation above 95%, and then after a couple of hours deteriorated and then ended up on ECMO. And as you can see, indicated by the red arrow, the start of the ECMO support led to certain physiological changes. We observed an increase, a sudden increase in the SpO2. It's actually at 100%. It's debatable whether it has to be like this, but that was the reality. It was like 1 o'clock in the morning. The ECMO team were initiating the ECMO, and then everybody was going home. And then the baby was left at this. The PaO2s were actually pretty okay, not too high. but the oxygen remained at 100%. And you can see with the initiation of the ECMO, we saw a drop in the arterial blood pressure and an increase in the heart rate. This is something that is quite common. So the acute changes after initiation of the ECMO is an increase in the PaO2 and the SpO2. We observe a decrease in the carbon dioxide levels, and usually this is associated with a decrease in the systemic vascular resistance, and also to some extent in the pulmonary vascular resistance. And we observe as a reflection to this an increase in the heart rate, so the baby can become tachycardiac. And also we have some other changes, and the cardiac function itself can either improve or sometimes, especially with veno-venous ECMO, we observe a worsening in the cardiac function in the first 24 to 48 hours on ECMO, which normalizes afterwards with the appropriate inotropic support. Also some changes in the electrolytes, lactate level decreases, metabolic abnormalities can occur, and with the initiation of the ECMO itself, the baby experiences an activation of the inflammation system and also of the coagulation system. These are all some changes that we have to account. And basically all therapeutic aims, I don't want to go into detail about the specific drugs at this moment, but the two main points is improving gas exchange and improving hemodynamics. So these are really the fundamentals that we have to consider every time we care about the patient. We want to improve the oxygen delivery and the amount of oxygen that is delivered adequately for this patient. And of course, it is also an important thing to avoid treatment-induced side effects, for example, from the ventilation, but also from vasopressors or inappropriate use of pulmonary vasodilators. I want to show you the x-rays of two kids. This was a left-sided CDH baby who was admitted at our hospital with quite a small lung, and the baby ended up on ECMO after a couple of hours. And as you can see here, the third picture is on day 2 of the ECMO run. So we saw an improvement in the right lung with a small pleural effusion. And at the third day, between the second and the third day, you can see here the baby observed or experienced a whitening of the lung, which is also called a whiteout, and a complete loss of the lung volume. Also, you see some increase in the fluid, some fluid overload, and we were not able to get this baby or get the lungs recruited in this baby, and this baby eventually died. So this was a kid where we had to use, before putting the baby on ECMO, quite a high pressure to keep the oxygen saturation above 60%. So then there was a certain kind of lung damage as well. And this, of course, is very bad for the prognosis. A baby that did better is this one here, similar severity of CDH, ventilated appropriately. ECMO was put in pretty early after birth. And as you can see here, same days as the baby before, we never had a whiteout of the right lung. The baby was operated on ECMO and was weaned from ECMO and is now doing fine. And so these are the two things that we really encounter, or the two extremes. So the lung is a very important point in the physiology of this baby. We have to keep the lung open, or at least recruited at a certain time point. But the lung is not the only component. Of course, the hemodynamics is very important, and you are probably familiar with this picture here. It shows very nicely the interactions between the pulmonary vascular resistance and the right and the left ventricular dysfunction. and how it may lead to hypoxemia and acidosis and systemic hypotension, and then aggravating of this pathophysiological circle. So in the CDH, in CDH babies, the pathophysiological trifecta has become a very common thing: the cardiac dysfunction, pulmonary hypertension, lung hypoplasia. This is also true for many other indications why babies go on ECMO. So we can see this also in meconium aspiration syndrome, although the term lung hypoplasia does not really apply for these babies, but we have a loss of lung volume. So you see that these are problems which are potential targets. So the mode of cannulation, if we start an ECMO, we have on one side the veno-arterial ECMO. This is shown in adult, but it's similar in a neonate. We have a venous cannula in the vena cava, and return arterial cannula in the aortic arch, or and in the venous cannulation, we most of the time we have a dual lumen cannula, which has the tip of the cannula in the inferior vena cava. There's also the possibility to use a multi-site approach with the jugular vein and the femoral vein. We have done this in a couple of kids, works also, but more commonly is the dual lumen single site approach. And here you can see a picture and an X-ray of a baby VA cannulated with the venous and the arterial cannula, and similar to this, we can see here an X-ray with a veno-venous cannula. So the question is always which mode is superior, veno-venous, veno-arterial. From my perspective, I can say veno-venous works quite well in the majority of patients. But the one argument that I always hear is that the cardiac dysfunction that we observe is a limitation for VV ECMO. I cannot really support this statement, because we see with a certain inotropic medication that the heart is really improving over time, and that the patient do not have persistent cardiac failure or severe cardiac dysfunction. So looking into the pros and cons, the pro of veno-arterial ECMO is the direct cardiac support. We have also an unloading of the heart, and we have a rapid stabilization, and the disadvantages are a higher risk for cerebral injuries. We have a increased risk of LV afterload, and also when taking out the cannulas, usually the carotid artery has to be ligated, which can lead, or is a supporting factor for the cerebral injury. The VV ECMO, it maintains the normal pulmonary blood flow, and also it has a precapillary CO2 removal. So the CO2 that returns to the pulmonary artery is quite low, which leads to probably a reduction in the pulmonary vascular resistance. And the disadvantages are, of course, no direct cardiac support. It is also difficult to put some of these cannula in. There are some newer cannulas which are not available in Europe, but in the US might overcome this problem. Looking at the data, there is an old study from 2009, and comparing veno-arterial versus veno-venous ECMO in CDH babies. And here you can see that there was not really much of a difference in the odds of mortality, but the complications were different. So I marked it here with a blue arrow favoring the veno-venous ECMO and the red arrow favoring the veno-arterial ECMO. So with veno-venous ECMO, we have a lower risk of neurological complications and a lower risk of cardiac stunning. And with the veno-arterial, the risk is lower for arrhythmias and metabolic abnormalities as a high glucose level and some impairment in the renal function. Not really dialysis, but the creatinine might be higher. And then there was a more recent analysis from the ELSO registry. And here it is important to really have a feeling for at what time point the patient came on ECMO. So those who received ECMO pre-repair had really no difference towards the ECMO, and those who went on ECMO after the CDH repair did actually better if veno-arterial ECMO was used. So what is the reality? Here's a picture of the data from the ELSO registry from 2022, and we observed there a certain decline in the rate or the percentage of babies being cannulated veno-venously. That was probably due to a shortage of the right cannulas, and in recent years we saw an increase. So it remains interesting whether this stays at this level or whether it don't. So how do we assess the ECMO patient? Well, of course, with the ventilator settings and the blood gases is important, but also the cardiac function and the pulmonary hypertension, and not only the right ventricle, but also the left ventricle. And you most commonly we assess the severity of the pulmonary hypertension by the tricuspid regurgitation and the ductus arteriosus flow pattern. The left ventricle is either measured by the ejection fraction, fractional shortening, tissue Doppler, or strain analysis. And it's the most common grading system, which relies pretty much on the PDA flow and tricuspid regurgitation. We saw in a study that we did that after 5 days, we were not able to assess either PDA or tricuspid regurgitation in 30% of the patients. So I want to show you different opportunities or chances how to measure this. Here's a study we have published 2 years ago. We're measuring the pulmonary arterial blood flow using the acceleration time. And as you can see here in the box plots, we were able to show a difference between ECMO and non-ECMO patients at the time point of admission. And then on the ECMO patients, we were able to see at the day of life 5 to 7 a difference in those who survived versus those who non-survived. So this is a parameter that is really associated with the pulmonary vascular resistance, and this might be an alternative to our other used parameters. And then another thing is a study from our institution published last year, where we measured the relation of the right to the left ventricle, because if you have in the condition that you have a high pulmonary vascular resistance, a high pulmonary artery pressure, you see a dilation in the right ventricle and a small left ventricle. And we were able to show that in those patients who had an abnormal ratio, the mortality was increased by a factor of 4. So the red dots are here, the control group. And as you can see, the amount of the non-survivors is much higher in those patients who have an RV-LV ratio at admission greater than 1.1. So this is also useful during ECMO. This is data in preparation, and we were able to see when we compare the ECMO to the non-ECMO patients, basically no difference in the ratio. But when we had a closer look to those who were on ECMO, the ECMO survivors versus the ECMO non-survivors, we were able to see and differentiate that those who don't survive have a persistent ventricular disproportion. So this might be also something that is useful for in the future. We have not, or we don't know whether the cutoff of 1.1 is appropriate, or whether we have to use something different. Assessing the lung on ECMO, very, very important, as stressed out earlier. You can either do it with electrical impedance tomography or lung ultrasound. I want to show you some data. The very important thing is to keep the alveolus open and not over distend it, because that can really affect the blood flow. You can see here in this cartoon the septal capillaries surrounding the alveoli, and in the circumstances here where you have an overdistension of the alveolus, the capillaries are compressed and the blood flow is not possible, which can lead to an increase in the pulmonary vascular resistance. And this is also shown here in this figure with overdistension, the ventricular, the vascular resistance increases in the lung. Additionally, when you have atelectasis, the corner vessels between the alveoli are compressed, and then you have an additionally also an increase in the pulmonary vascular resistance. So keeping the lung open is really important. And this is a study from Lucas Schröder, a colleague of mine, who has done some nice investigations using electrical impedance tomography. And this is really a tool where you can see which is the most appropriate PEEP level. And in the CDH babies before going on ECMO, we were able to define a PEEP of 2, which might be most appropriate for these babies. Probably on ECMO, the babies need more. This is something that still needs to be investigated, but I want to introduce this technique to you because it's really something excited that we will probably see much more in the future. Also, the respiration itself has an impact on the lung, so we really have to work on that, and we have to consider that if the patient on ECMO is not doing well. So the positive pressure can lead to an increased right atrial pressure, which can lead to a decreased RV preload and a reduced pulmonary blood flow. So this might be something that you can experience when you have a patient on ECMO with inappropriate ventilator settings. Additionally, as mentioned before, the alveolar pressure is important for the pulmonary vascular resistance, keeping the alveoli open and at the right position, and the positive pressure ventilation can also lead to an increased left ventricular preload, and can also improve the left ventricular dysfunction to a certain amount because the transmural pressure is reduced. So the left heart is supported with its capacity to eject blood. This is something that we might want to use when we have a patient who is not doing well. So it comes always back to the question, which is the leading problem? What do we have to target? What can we do? And I want to show you a typical picture of one of our VV CDH ECMO babies. As you can see here, pre-ECMO, the baby really has a poor right ventricular function and a small left ventricle with a reduced function. And after 24 hours and 3 days on ECMO, the cardiac function gradually improves. And at 7 days of ECMO, you see almost a little bit of an over distension of the left ventricle, but the function itself is really nice. So the baby can recover, or the ventricle can recover. Different scenario. Here you can see a baby that was on very high pressors, no inotropes, and you can see this ventricular bulging. So with the use of inotropes, we saw an improvement after 2 hours and after 18 hours. So this is a situation where we really have this left ventricular phenotype, which may lead to post-capillary pulmonary hypertension. And this is a very busy slide, but I want to show this because it is on one hand, we have to use this before for the patient with pulmonary hypertension or with respiratory failure, but we can also apply this to our ECMO patient. We always have to differentiate it. Is the left ventricular the leading problem, or the right ventricle, or do we have a combination of both? Do we want to have inotropes to support the left ventricular function, or is it more appropriate to use a pulmonary vasodilator such as nitric oxide or sildenafil, and also under circumstances where the left ventricle is not working well, it might be useful to avoid nitric oxide because we increase with pulmonary vasodilators, we increase the pulmonary venous return, and this can further impair the already impaired left ventricle. And sometimes it might also be appropriate to keep the duct open with PGE1. And of course, we have these cardiorespiratory interactions that we need to account. So use of lungs ultrasound, or if available, EIT might be something that is helpful in this setting. Very briefly, I want to mention the complications that we see during ECMO. This is quite old data, and it shows that we can differentiate between mechanical failure and or mechanical problems and patient-related problems. And here is highlighted bleeding problems. Bleeding is a very common thing on ECMO, and it really increases the mortality. And then there are other things such as hemolysis, which is also important because if you have a patient who's producing free hemoglobin, that can lead to endothelial dysfunction, and this can increase further the pulmonary vascular resistance. And so this is really something that we have to consider. And for the sake of time, we have to stop at this point. I'm looking forward to a nice discussion.
Thank you so much, both of you.